I'm Dr. Christine Daniels, and I would like to welcome all of you to our Busting Breast Cancer Myths to Save Lives congressional briefing. We would like to share with you some of our efforts to raise awareness about the importance of breast density and getting accurate diagnostics for breast cancer. Throughout the call, please feel free to drop your questions into the Q&A box, and we'll do our best to get to them after the brief presentations. Before we begin, I'd like to share with you some of the ads from our recent campaign to raise awareness about breast density and to urge for extended coverage for these diagnostics. For the first one, we want to emphasize that all women don't benefit equally from mammograms. This is particularly true if you fall into the category of women that have dense breasts. While mammograms may not be the most effective tool for women with dense breasts, there are tools that are able to see tumors in that dense breast tissue. And so we urge you to learn your options about which breast imaging option is best for you. Lastly, we all are very well aware that cancer doesn't just touch individuals, it touches families and communities. First, we are so honored to hear from two Congresswomen, Congresswoman Rosa DeLauro and Congresswoman Jan Schakowsky. Both women are passionate about ensuring that women with dense breasts have access to the right diagnostics for their breast tissue type. Congresswoman DeLauro is a ranking member of the powerful House Appropriations Committee and its Subcommittee on Health. She is the author of the Find It Early Act and has, as well as many pieces of legislation over the years that have been addressing vital issues in women's health. Congresswoman Jan Schakowsky, who is senior member on the Energy and Commerce Committee and its Subcommittee on Health, has also championed breast cancer and women's health legislation over the years. Without any ado, here's comments from them.
Hello, everyone. This is Congresswoman Rosa DeLauro, representing Connecticut's 3rd Congressional District and ranking member of the House Appropriations Committee. Thank you for inviting me to say a few words and join you all virtually today. This briefing on busting breast cancer myths is so important because it will help save women's lives. This is personal for me. I am a 36-year cancer survivor. I'm alive today thanks to the grace of God, the care of hardworking medical professionals, the power of biomedical research, and early detection. That is why I was so proud to introduce the Find It Early Act with Congressman Brian Fitzpatrick alongside Katie Couric. This legislation would ensure all health insurance plans cover screening and diagnostic mammograms and breast ultrasounds and MRIs with no cost sharing. Since it was announced that I am working on the Find It Early Act, I have women coming up to me at many events that have nothing to do with breast cancer, saying, and I quote, "I have dense breasts. 40% of women over 40 have dense breasts, and therefore their risk of breast cancer is much higher, but it is harder to detect in the mammogram." My home state of Connecticut, because of the late Dr. Nancy Capello, led the way in requiring the information women and their healthcare providers receive after a mammogram includes a patient's relative breast density, as well as information on the need for additional screenings to find breast cancer. The FDA has finally committed to a timeline to roll out a rule requiring providers to notify women of whether they have dense breasts, what this means for their risk of breast cancer, and the importance of speaking with a healthcare provider about breast density. It is imperative that all women, regardless of where they live or their insurance, have access to these critical additional screenings without any additional costs. As we all know, when it comes to surviving cancer, early detection is key, as 99% of women who receive an early breast cancer diagnosis survive it. Let me be clear, women's lives are at stake. That is why I'm fighting harder than ever to pass the Find It Early Act. It is long overdue that we mandate all insurance coverage to cover screening and diagnostic mammograms, breast ultrasounds, and breast MRAs with no cost sharing. And I want to thank Sheila McHale, Dr. Rachel Brem, and Leslie Yerger for transforming their own personal experiences with breast cancer into meaningful action that will save countless women's lives. And thank you to Dr. Covington and Dr. Daniels for sharing your expertise and being incredible advocates for patients. And I want you all to remember that Congress is an institution that responds to external pressure. Continue speaking out, making your voices heard, and do not take no for an answer. This truly is our moment.
Hi, I'm Congresswoman Jan Schakowsky. I represent the 9th Congressional District of Illinois. And I want to thank Sheila McHale, who is head of Breast Cancer Ruckus. And I appreciate the work that she's doing to save women. I want to talk to you about dense breasts. Do you have dense breasts? Do you know if you have dense breasts? It is not something you can discover by just touching or having a doctor or anyone just feel your breasts. Now, it can be identified by a mammogram. But I know that I have dense breasts, but I was never told. So lots of women, even those of us who do not know. You can ask the person who is giving you the mammogram because they should be able to tell you if you have dense breasts. Why is it important to find out? Because first of all, 40 to 50% of women do have dense breasts. And women who have dense breasts are more likely to get breast cancer 4 to 5 times as often as women without dense breasts. So this is something really important to find out about, especially during this month of Breast Cancer Awareness Month that you want to find out. Well, we want to do something about it in the Congress as well. My colleague, Congresswoman Rosa DeLauro, has a bill, hasn't passed yet, we have to get it passed, called Find It Early. And I am very proud to be a co-sponsor of that legislation to make sure that all women are aware. But here's the other problem, and that's addressed in this legislation, is that while a mammogram is free and covered by insurance, that is not true if you need a different kind of test to discover whether or not you have cancer when you have dense breasts. We want to, in this legislation, make sure that that screening is available at low or no cost so that you don't get turned away because it may not be covered by insurance. It could cost up to $800 to get the kind of screening that you need to find out if you have cancer when you have dense breasts. So this is a really important issue. We're trying to bring it to attention, to have you pay attention and to find out what your situation is, and then to fix it so that you will be able to get the screening that you need and the care that you need in a timely way. That's my mission, and I hope you'll help us. Thank you.
All right, so both Congresswomen gave a great summary of the issue that we'll be covering today. Very briefly, I'd like to introduce you informally to the panelists and experts that you'll be hearing today. Next, we will hear from Sheila McHale. Sheila is an inspiring Hispanic female CEO and serial entrepreneur with one of the most successful exits in the health industry in North Carolina and nationwide, with her sale of AskBio in 2020 to Bayer for $4 billion. One of her proudest achievements is launching Columbus Children's Foundation to ensure children with rare diseases obtain effective treatments using patient-specific genetic engineering. Sheila has won many awards, including the National Entrepreneur of the Year and Fiercest Women in Science. However, despite all of her success, prestige, and access, even she was denied access to the diagnostic care she needed. Sheila?
Thank you, Christine. I was surprised last November to find a dimple on my left-hand side. I had just had a mammogram at Duke earlier in the year. I had 3D tomosynthesis. I knew that I had heterogeneously dense breasts, so I had spoken to my doctors several times about whether I needed something more. I received many assurances that 3D tomosynthesis was meant for my breast type. I had had mammograms probably for about 15 years. So, never really had any problems. At the request of my family, I went in for a diagnostic mammogram. At first, I didn't think I needed to go in. I was getting a little bit older, so I thought maybe it was just cellulite since I had gained a few pounds. But I went in for the diagnostic mammogram. The dimple on my left breast was marked with tape, and a diagnostic mammogram was performed on both sides. Ultrasound confirmed a tumor on the left-hand side. I had a biopsy, both of the mass, and there was a suspicious lymph node. 10 days later, Duke confirmed a 2-centimeter tumor, and the pathology indicated it was slow growing. Later, the oncologist said that the tumor was probably growing for about 10 years. So there was lots of opportunity over the many years of mammograms to pick it up. But again, it never showed up on any of them. I met with the oncologist after the biopsy results came back. And I asked her just simply, how do you know it's not on the right-hand side? And she assured me, she said, well, you had diagnostic mammograms and nothing showed up. And my response to her was, I don't believe these mammograms. Clearly, the slow-growing tumor on the left-hand side would have been picked up at some point, right, over many years of mammograms. So I demanded a CT, breast MRI. I didn't even know what to ask for. I said CT, MRI, something. There must be something better to detect it, make sure that there's no cancer on the right-hand side. And I got pushback. I was told, first of all, it's not the standard of care. Then I was told that insurance would not pay. The insurance would not pay was ridiculous because I had just sold a company for $4 billion, which I had a substantial stake in it. So I just said self-pay, and I started really pushing back hard, self-pay, self-pay. Then, she told me essentially I was creating a ruckus. Well, I got that breast MRI, and it came back. And it confirmed the tumor on the left-hand side, but it was actually 3 centimeters larger than what the mammogram anticipated. And it showed a new malignancy on the right-hand side. I had 6 centimeters of malignancy on the right-hand side. And I don't know the metric system very well. Maybe you all do, but as point of reference, that's about the size of my thumb. And that had not shown up on several years of 3D tomosynthesis, nor did it show up on the diagnostic mammogram that, I just had a few weeks ago prior to the MRI. So this was incredibly upsetting. I had hoped that I was wrong. I went from having no breast cancer, no family of breast cancer. I eat well, I exercise, I see doctors, at least have physical checkups 3 times a year. I had breast exams by my GYN every year. By my primary care physician, never saw anything. I did my own breast exams. There was no lump. Although I did have very fibrotic breasts, there was no new lumps. I had surgery 2 months later to remove the tumors. It was very questionable about whether I could get a double lumpectomy because the tumors were so large, but there was a very talented physician, Crystalline Gallagher over at UNC, who was able to remove the tumors. It was a 5.5-hour, 6-hour surgery, but I was very grateful that she was willing to give it a chance. She said if she wasn't able to remove them, then I was going to have a second surgery for a double mastectomy. It was really questionable about whether or not she could get the tumors out. Amazingly, and again, by the grace of God, it was successful. I had no chemotherapy because my type of tumor, it wouldn't have been beneficial. But I did have 66 radiation treatments. I had to step down as CEO of the company that it took 20 years to build. So it was really a very transformative result. And, going forward, right, with tumors that large, we just watch and see what happens. I'm very optimistic, but, I could have gotten these tumors caught much earlier if I had had the right screening tools. I formed BC Ruckus to educate other women. I was very well educated, but I honestly was focused on what I was supposed to do, building companies, created, a company that went from me as the first employee in 2017 to 800 people over 5 years, raised $235 million, exited in a $4 billion deal, brought 6 things in the clinic. I was doing what I was supposed to do. And I relied on my doctors to do what they were supposed to do. But I think that many doctors are not well educated on this issue. And I think patients are often misinformed. The people who have the knowledge, the radiologists, aren't stepping up and really vocalizing the issue as much as they should be to patients. And then I think the number one barrier is insurance coverage. Insurance often dictates the standard of care. Christine, if you go to the next slide, this was my mammogram report at the beginning of 2022, just to really drive this home. I was trained as a lawyer, and this is very confusing, right? You have to almost parse it apart. It does say very clearly there are no suspicious masses, calcifications, or other findings in either breast. And it says there's no evidence of malignancy. Recommend routine mammography screening in 1 year. That's very clear. Then there's this sort of disclaimer, right? And I guess I should have been more alert with my legal training. But again, you don't go into, that kind of mindset when you're working with your doctors. But it says that the breasts are heterogeneously dense, which may obscure small masses. And in fact, in the Duke system and my charts, you can press on a button that tells you exactly what that means. And, it just says it somewhat limits the ability of a mammogram to find small abnormalities, and it's normal to have dense breast tissue. There's nothing really alarming. In addition, I had gone to my doctors and I had asked them for guidance. And I said, do I need anything more than 3D tomosynthesis? And first of all, a lot of times 3D tomosynthesis is marketed as being the supplemental screening. You are getting supplemental screening. So I thought, okay, I'm getting it, right? And, they said, Nan, you don't need anything more. 3D is meant for heterogeneously dense breasts like yours. If there was something abnormal in the mammogram report, the radiologist would do additional tests. There's nothing, so don't worry about it. You have no family history. Getting something different is not the standard of care. You're in, to your doctors 2 times a year for physical exams. You do your own self-breast examinations. And, I later found out one other big factor that wasn't articulated to me at the time when I had asked, and I asked repeatedly if I needed something more, was insurance won't pay. And I think that is a bigger factor than I initially had anticipated. I went back and talked with my GYN specifically, and he said, one big factor for him in not recommending something more was insurance won't pay, which makes me very angry because, a woman should have the choice of whether she wants to buy another plasma TV or whether she wants to pay for an additional test to find her breast cancer early. I did not have that opportunity. And I think breaking down the insurance barrier will not only help women who maybe don't have the resources to pay for the additional testing, but will help all women. So everybody is given an opportunity to pursue the additional screening. So I want to thank Congresswomen DeLorio and Schakowsky for their bravery in articulating this issue and really leading the charge on making change for women. We deserve better. We say we have the best healthcare system in the world. I work hard to develop drugs and genetic diseases to make it the foremost best healthcare anywhere. But when it comes to this issue, we are not. If I had been in Europe, the key countries there, even though they have socialized medicine, provide supplemental screening for women with dense breasts. We have to do better in this country for our women. Thank you for listening.
Thank you so much, Sheila, for sharing your experience and for using your pain and turning it into something proactive to make the experience for other women better. We really appreciate the work that you've done. Our next speaker is Dr. Covington. Dr. Covington is a dual specialty trained radiologist in breast imaging and nuclear medicine. He's also an assistant professor of radiology at the University of Utah and Huntsman Cancer Institute. Dr. Covington is the principal investigator on multiple clinical trials on PET imaging for breast cancer, as well as for contrast-enhanced mammography. Dr. Covington is the founder and host of the Radiology Review podcast, which has a wide international audience for radiology education. And he's also collaborated with news anchor Katie Couric to raise awareness of this issue. Dr. Covington?
Thank you. As a radiologist, I'm trying hard to communicate when a mammogram is likely to work better and when a mammogram might have a harder time detecting breast cancer. And what I'm showing here on this slide are the 4 categories of breast density that every radiologist in the United States is required to include, meaning every mammogram report will have a statement of what the breast density on that mammogram is. And there's 4 categories. 2 of these are considered non-dense, and that's A and B here, the fatty and scattered fibroglandular density. And 2 of these are considered dense, which is C and D. And in these cases, the radiology report would say heterogeneously dense or extremely dense. Now, I want to show you exactly what this means in practice. And when I'm interpreting the mammogram, cancers often look like this little jagged gray dot that is circled. And as you go across the density categories, notice how this is extremely easy to see on the fatty and scattered breast, but it becomes nearly impossible on C here, the heterogeneously dense breast, and then on D, you absolutely cannot see it. And this is literally the problem that we face each day on screening mammography, is that on certain cases, the cancer is very easy to identify, and that's fantastic. That's mammography doing its job that it's supposed to. But in other cases, we simply cannot see the cancer. So what does this mean? First of all, it means, especially in someone with dense breast tissue, that if the mammogram report says negative, no evidence of malignancy, that simply means that the cancer was not seen. But that does not mean that no cancer is present. We absolutely know that a cancer could be there, but we simply can't see it with mammography. What this also means is that some women are likely to be better screened than others. And what I mean by that is women or anybody having screening mammography, the cancer, if it's present, would be much easier to see in a non-dense breast, and it may be very difficult, if not impossible, to see in a dense breast. And those disparities are something that I think we need to pay a lot of attention to, because I believe that everybody who comes in for breast cancer screening should have an equal chance and the best chance possible to have cancer detected early when it's still curable. And that when we apply technology that can't do that, it's something we need to think really hard about. Now, that doesn't mean we don't continue with screening mammography, but what it does mean is we might need other technologies to help us here. And if we can go to the next slide, I have a few examples here. So DBT, that's tomosynthesis, that's also known as 3D mammography. And here we have the arrow showing an area that, is maybe questionable, but not definitely abnormal on the DBT image in this dense breast. CEM is contrast enhanced mammography. Here you can see that the dense breast tissue through the technology that's applied is removed from the image, and we see enhancement at the site of cancer. MBI is molecular breast imaging. It's another option that allows us to see through dense breast tissue and see that there is actually a cancer here that's lighting up. And then MRI, which people are generally more familiar with, is on the far right, and it very clearly shows a highly suspicious mass in this breast. I want to also mention that ultrasound has a role to play with dense breast tissue screening. We will have Dr. Brem discuss that further, and I appreciate the chance to present this to you.
Wow. Thanks, Dr. Covington. A lot of times we speak about dense breast tissue, but it really makes the point drive. It really drives home the point when you can actually see those images and see how difficult it is to find a tumor in women with dense breast tissue. Now we'll hear from Dr. Rachel Brem. Dr. Brem is a world-renowned expert in breast health, specifically dealing with dense breast and breast cancer treatment. She is the Director of Breast Imaging and Intervention and Professor of Radiology at George Washington University. Dr. Brem has received many awards, honors, and recognition, including Newsweek's Top Cancer Doctor, Jewish Women International 10 Women to Watch, the International Biographical Center's Woman of the Year, and recognition as Who's Who among American women. She has also launched a nonprofit called the Brem Foundation to defeat breast cancer and co-authored with Dr. Christy Teal the book No Longer Radical, Understanding Mastectomies and Choosing the Right Breast Cancer Care is Right for You. Dr. Brem, we'd love to hear from you.
Thank you so much. Thank you for the kind introduction and for the opportunity to be part of this critically important congressional briefing about the need for multimodality imaging in women with dense breast tissue. I'm here today as an expert in breast cancer who has devoted my life to improving the outcome for women with breast cancer, but also the daughter of a woman diagnosed with breast cancer at age 33, a breast cancer survivor myself who found my own breast cancer that was not seen on my mammogram while trying ultrasound equipment for my patients, and the mother of 3 daughters and 6 granddaughters who deserve, like all American women, the best chance for a cure. We have indeed made outstanding strides in the death rate from breast cancer, which has decreased by over 40% over the last 2 decades. This laudable achievement is due to improved screening and therapy. Yet with that in mind, this year alone, over 45,000 women will die of breast cancer in the United States. This should not be. Early stage breast cancer is essentially a curable disease with over a 96% 5-year survival. So why do so many women continue to die of breast cancer? The answer is largely to the detection of later stage breast cancer. And one of the most common causes for the delayed diagnosis of breast cancer is indeed what you've been hearing about, dense breast tissue. On a mammogram, as you saw and Dr. Covington showed us, dense breast tissue is white. But so is breast cancer. So there's no contrast. And identifying cancer is very difficult in women with dense breasts, much like trying to find a specific cloud on a cloud-filled sky. To further complicate the situation, women with dense breast tissue have a markedly increased risk of breast cancer, up to 4 times higher. So we have the perfect storm, harder to find and higher risk. So you might say that that's not important because maybe few women have dense breast tissue. But as you heard, more than 40% of American women indeed have dense breast tissue. And the result is that we find too many later stage breast cancers with devastating consequences. However, we can find these hidden breast cancers with additional imaging modalities, such as ultrasound, MRI, molecular breast imaging, and contrast-enhanced mammography, as well as a new technology, ultrasound tomography. The reason for these additional modalities and the reason these can help us find mammographically hidden cancers is that each modality uses different technologies, allowing us to see different characteristics of tissue. For example, with ultrasound, breast cancers are black and breast tissue is white. So the contrast is optimized to find early breast cancer. And if I could have the next slide, please. There you go. On the left, you see a dense breast, a mammogram. And in the center, you see a black hole in the white area. That is the same person where nothing is seen on the mammogram, but that big cancer is indeed seen on the ultrasound. And what you see is one of many technologies being developed to further advance the imaging of ultrasound breast cancer. So the cancers that these modalities allows us to find are really important cancers. And you might say, well, every cancer is important, and that's true. But the cancers that these additional modalities allow us to find are generally small, largely node-negative, invasive breast cancers, killer cancers that if we find them early enough, we can effectively treat and cure. We have to remember that when we think of breast cancer, we often think of outcomes as survival. However, we also have to consider the intensity of care, where we need to consider a woman's journey as she goes through treatment. With earlier detection of breast cancer, the journey is associated with less invasive surgery, less frequent chemotherapy, and less frequent radiation therapy. The other critical issue is that breast cancer is not an equal disease. It's noteworthy that in the District of Columbia, we have the highest death rate of breast cancer in the country by a lot. Currently, women with dense breast tissue have later, less curable cancers diagnosed more frequently. Additionally, underserved women and women of color die at a much higher rate, with 40% higher death rate from breast cancer in Black American women. So we can't rest on our laurels that we now have technologies to help us find these hidden killer cancers, but we must make these technologies available to all American women of all socioeconomic levels. And we must not forget our military and the VA, who have a higher rate of cancer and who deserve the best care. Only when all women have access to these life-saving tests will we be able to move the needle and further lower the death rate from breast cancer. Currently, screening mammography, as you heard earlier, is no cost to women as a result of the Affordable Care Act. But today, many women must choose between putting food on their dinner table or getting the life-saving additional testing that they must have and deserve to detect early curable breast cancer. That's why we're here today, to do all we can to cooperate and collaborate to make life-saving additional breast imaging available to all. That includes ultrasound, ultrasound tomography, MRI, molecular breast imaging, and contrast-enhanced mammography at no additional cost to them, so they can avail themselves of these life-saving tests without needing to make harrowing choices, basic needs for their family or life-saving tests for them. That's why we must assure coverage of all imaging modalities to help us find these important, hidden, and life-threatening breast cancers at no cost to women, so that any woman diagnosed with breast cancer can have the best chance for a cure. We owe that to them. Thank you very much.
Thank you so much, Dr. Brem, for that introduction to the various technologies, and also for iterating a point that people don't always focus on. But we can have the best technology available, but if it's not accessible, then it's not helping the people that need it most. So thank you for that word.
Thank you.
After hearing from these amazing experts who have illuminated the importance of breast density and various forms of imaging that can be used for accurate early detection, we would like to close with our policy recommendations from another patient turned advocate. Leslie Yerger is a TEDx speaker and author of Probably Benign, which details her story of her breast cancer journey. She's also founder and CEO of the nonprofit My Density Matters, which seeks to empower women to find out their breast density, learn their options, and advocate for themselves to get the additional breast screening they need. Leslie.
Thank you very much for allowing me to be here today. I am honored to be here to speak about a topic that I am so incredibly passionate about. As Christine said, my name is Leslie Ferris Yerger, and I'm CEO and founder of My Density Matters. I was diagnosed with stage 4 breast cancer about 5 years ago now, 2 months after an all-clear mammogram and ultrasound, after what we call an incidental finding when I was just getting a routine DEXA scan. That's a very long story about how all that came to be, but let it suffice to say that I was shocked to learn that my cancer could not be seen through my dense breast tissue, and that my cancer was not discovered until it had already metastasized. So when that happens, when the breast cancer spreads from the breast to somewhere else in the body, like mine has done to the bones, there's no cure. There's no way to get rid of it. There is no going back. There are treatments that can work for a while, but there is no cure. The 5-year survival rate for someone diagnosed with stage 4 breast cancer is around 25 to 30%. Those are not good odds, but I'm happy to say that to this point, I am defying the odds. We aren't here today specifically to talk about metastatic breast cancer, but to be clear, big picture, That's exactly what we ultimately are trying to prevent. Because metastatic breast cancer is brutal, expensive, and ultimately fatal. About 45,000 women die of breast cancer every year alone in this country. And I know that's uncomfortable to talk about. I understand that, but that's the harsh reality and why we're really here, to keep you, your family, your friends, your coworkers from dying from breast cancer. I don't want my story to become your story or anyone else's story. So that's why we at My Density Matters empower women to find out their breast density, learn their additional screening options, and advocate for themselves. And that goes pretty well. We know how to do that. But when they actually try to do it, there's a big barrier that keeps them from getting what they really need. You've heard the facts from Dr. Covington and Dr. Brem, and they are undeniable. Mammography alone, including 3D, is not enough for women with dense breasts. And yet, with rare exception, that's really all that's on offer and all that's consistently covered by insurance. That's the barrier that I'm talking about. The additional screening women need is not covered, and that's very, very often the showstopper. As you have learned today, breast density hinders the early diagnosis of breast cancer when mammography is the only tool available. This fact alone leaves millions of women vulnerable to later stage diagnosis, much to their peril, to suffer harder and more harsh treatments, or worse yet, a terminal diagnosis. Advanced later stage cancer is costly in terms of dollars, yes, but also it's cost families, it costs livelihoods and longevity for women. The consequences are dire. Many women with a later stage diagnosis cannot keep their jobs, as Sheila mentioned earlier in the presentation. Healthcare costs are a significant reason for bankruptcy also in this country. So we're calling for Congress to act to provide insurance coverage for those necessary additional screening modalities women with dense breasts need, so their cancer can be found early. Passing legislation that would provide the right screening for those with dense breasts would eliminate the very barrier that women face when they try to get their cancer found as early as possible. This would include the ultrasound tomography, MRI, molecular breast imaging, contrast enhanced mammography, and other modalities that find additional cancers early. These technologies are here, they're now. They could be used at a much bigger extent than they are right now, but largely they're not covered. So they're not used to save women's lives. We don't have to wait. We've got it now. It's here. We're ready. If women were able to find their screening early, get screening that they need to find their cancer early, we could be saving lives now. That's why we're here today and why we're asking Congress to pass legislation that will give women who need it the ability to find their cancer early. Something like the Find It Early Act, which was introduced into Congress last year and then reintroduced this year. Something that covers for all women, no matter where they live, who they are, or how they get their health care. Breast cancer spares no one. Anyone can get it. We're asking Congress to help the women of this country find it early and take down the mortality rate from breast cancer. We can do this, and we can do it now, but we need insurance coverage for all women. Advocates, please speak up, be vocal, insist and persist, and please sign the petition shown on your screen. Congress, we need you. Let's do this. Thank you. And Christine, I think we have some questions from the audience. So thank you very much.
Yes, thank you, Leslie, for reiterating that message. Thank you for sharing your story. And also for putting emphasis on the fact that prevention is the best tool we have to reduce mortality, as well as all of these advanced technologies. So I want to thank you again for sharing those insights, all of our speakers today. We'd like to now take your questions in the Q&A, and we also have additional experts participating on hand to answer these questions in our panel discussion. So if you haven't already, please take the time now to post your questions in the Q&A box, and we'll try to get our best to get to as many as possible. This is your opportunity. Use your voice. We already have a lot of questions, so we'll get started. The first question comes from Jennifer McCann, and she wants to know, sorry, I'll wait for all the panelists. Okay. The first question comes from Jennifer McCann, and she wants to know, once you're diagnosed with dense breast tissue, should an MRI be repeated every year?
I'm happy to answer that. If you have dense breast tissue, a mammogram is not enough. You absolutely need additional screening. It may be ultrasound may be sufficient. It really depends on how high your risk is. So if you have dense breast tissue, no other risk factors, an ultrasound may be sufficient. If you have additional risk factors, you might need something more like contrast enhanced mammography, molecular breast imaging, or MRI. And when you have ultrasound, it could be ultrasound or ultrasound tomography. But so it's really about risk-based screening. We don't do an MRI every year on every person because it requires an injection of a compound that we've recently found accumulates in the brain. So we have to use it somewhat judiciously.
Thank you for that answer. We actually have another question for you, Dr. Brem. An anonymous attendee wants to know, how are the screening recommendations for women with dense breast and those for women with genetic predispositions to cancer, such as BRCA1, BRCA2, or other mutations, similar or different?
They are different. What we have is risk-based screening. So if you have a BRCA mutation, or if you have one of 70 genes that are associated with a substantially increased risk of breast cancer, we generally recommend that you start screening at 25 with MRI, and then at 30 get a mammogram and an MRI every year, alternating at 6 months. If you have dense breast tissue, we recommend starting to screen either at the age of 40 every year, or 5 to 10 years earlier than your first degree relative with breast cancer, and get additional screening with ultrasound, at least, if not additional modalities as well.
Thank you for that answer. Another question we have, sorry, we have so many great questions. I'm trying to get a good sampling. Someone wants to know, and this is open to anyone on the panel, is there any effort to develop a single technology that can detect breast cancer in all tissue types? Mammograms are so barbaric and painful. There has to be a more effective and more comfortable tool in our pipeline.
Sure, I can start with that one. So yeah, the good news is we have many technologies that already exist. That can work very well. We don't necessarily have to develop an additional technology to make a substantial impact today. If we simply implement our alternative technologies that currently exist that we've run through, our breast cancer detection rates in dense breast tissue would be vastly improved compared to screening with mammography alone. There will, I anticipate, be future technologies, and we'll continue to get better. That's part of progress in medicine. But I think what I really want to drive home is the technologies are already here to largely make a huge dent in this in this problem we've described with dense breast tissue cancer detection. So yeah, I do think future technologies will be helpful, but let's not lose sight that we simply need to use the technology that already exists, already has been studied. We know it works. We just need to get access to it.
Yeah, if I could follow up on that, I'll say that several of the speakers have talked about the value of ultrasound, and ultrasound is a non-invasive, non-ionizing imaging modality, which is actually really effective in about 50% of women with dense breasts. So the cancer detection rate is better than it is with mammography and tomosynthesis, but it's not quite as high as it is with molecular breast imaging, with contrast enhanced mammography, and with MRI. MRI is considered the gold standard. So it has a cancer detection rate of well-accepted numbers of about 14 cancers per 1,000 people. And contrast enhanced mammography is about 13 cancers per 1,000 people. And molecular breast imaging is about 12 cancers per 1,000 women that are scanned. So just as Dr. Covington just said, we've got several technologies that currently exist. They're FDA approved, and there have been many clinical studies to show that these are effective technologies and they're available to the public today.
All right. Does anyone else have anything to add to that?
And I want to add that we also have artificial intelligence that's helping us find additional cancers, even with women with dense breasts, and that is also FDA cleared. So we have a lot of, as was said, we have a lot of tools in our tool chest. We just have to have the opportunity to use them.
Thank you for that. Okay, so with that, I'll move on to the next question. And I think this one's really going to get a lot of response from people on the panel. So Emily White wants to know, what is the reason payers don't want to cover these procedures for patients with dense breast tissue?
Money. It's that simple. It's money. I think that's one thing that's very frustrating to me, because if you look at the treatment cost for early stage versus late stage diagnosis, it's much cheaper to treat a woman when she's been diagnosed at the early stage. So if you look, and there's been people have done financial modeling, the costs are overall much cheaper if you diagnose women early. But the problem is here in the US, people change insurance companies so frequently, right? That people, I think insurance have a very short-term orientation. A mammogram costs $85 to $90. And in my state, where I've been really pushing for state laws in addition to federal law to have expanded insurance coverage, it's clear that some insurance companies don't want to pay more than that amount per year for screening. My life is worth more than $85 to $90. So I'm probably giving a very emotional response about this. And it's further aggravating, I think, because women pay more in their healthcare premiums, right? We always pay more for our healthcare costs. So I don't really understand it other than it's money. And I'm sure, Martin and Matt and Rachel can provide some more detailed explanation. But I think if you digest it all, that's what it comes down to.
So there is no more detailed explanation. It is money. But I also want to reiterate what Leslie and Sheila said, which is raise your voice. You can make a difference. The Brem Foundation was instrumental in passage of the breast density notification law in DC that does require insurance coverage for these additional tests. And there are now 9 states, I believe, that require insurance coverage, but we have to make it available to everybody across the country.
And we do have a petition. We're asking people to sign on if they go to BC Ruckus. We have a link to the petition. Again, I think that's important. Leslie's website, My Density Matters, really has a lot of good information, so people understand more fully why this is something that they have to stand up for, not only for themselves, but for their neighbors, their wives, their sisters. I mean, this is their daughters. This issue affects everybody. We should have better protection so we have our breast cancer found early. And unfortunately, like I said, I think doctors also have to be educated. I mean, I went to 2 of the best medical centers in North Carolina, arguably in the country, and I was continuously reassured that 3D tomosynthesis was meant for my heterogeneously dense breasts. Do not worry. If you get that message, and I know a lot of women in my circles get that message all the time. If you get that message, you have to speak up and you have to be armed, because you will get pushback. You have to be armed with the facts. And so I really, highly recommend going to Leslie's website, My Density Matter. Print the information, go into your doctor's appointments and demand, right, that you get the right screening. This is your life on the line. At the end of the day, the doctors go home to their families, and if you don't get the right screening and your cancer is not caught, you go home to a nightmare.
Thank you, Sheila. And I'll just add that a radiologist that I work with once told me, he said, if you women want this to change, you're going to have to make it happen. So that's what we're trying to do. And we need the help of Congress, and we need the help of every woman out there to understand the issue, be vocal, be loud, and insist and persist until we get what we need in this country, because it is a deadly disease.
And one other thing, not just with the radiologist, but if you are denied by your insurance, that is not a fait accompli. You can call, you can advocate for yourself in every forum. And we have many patients here. We offer screening ultrasound because we're in DC to all women with dense breasts. But if you need more and the insurance companies don't approve it, we tell our patients to call them, call back again, call again, get a peer-to-peer. A no is not necessarily a no. In this case, no is not no.
I think it's important to remind everyone that early detection will confer a 99% survival for the rest of your life, whereas a late detection, especially for one who has dense breasts, might only be a 30% or 25% chance of 5-year survival out if it's caught too late. This is certainly an issue that Dr. Brem and Dr. Covington might be able to comment on as well.
Yeah, I think we've had a lot of comments that iterate early detection is exactly what we need, and we need the right tools. But let's talk about rationale, because a lot of patients' experience in medical settings is that they do ask for these therapies for access to supplemental imaging, but they're faced with pushback. And so I'd like to pose a question to the panel, and that is do we have the evidence to support the efficacy, to justify the statements of efficacy we have for the need for supplemental insurance for dense breast? Supplemental imaging for dense breast. And what is that evidence? How do we know that this imaging does improve detection?
Well, we have a plethora of rigorous scientific evidence of multiple imaging modalities that we know with ultrasound, we can find 25% more killer cancers in screening ultrasound in women with dense breasts. MRI, the number is higher. There was an amazing study. The only risk factor was that women had extremely dense breasts, finding substantially more cancers. It's true of all of these technologies. It's true with single institution, multiple institution, rigorous scientific data. So there is no question that these are necessary, scientifically proven, based on rigorous data, that we need this in women with dense breasts. And even with artificial intelligence, it can find more cancers in women with dense breasts. So there's a lot of tools in our tool chest.
Yeah, I strongly agree with that. The problem is definitely not on the scientific evidence side. The science is very strong. The problem is on the policy side, and that's where we really need to focus our efforts at this point.
Okay.
I was just going to add, I myself have read papers in JAMA, right? New England Journal of Medicine. They're peer-reviewed papers. I mean, even somebody like me, now that I'm attuned to the issue, I've done, just Google searches. There are so many papers out there I can't understand, right? And huge studies that have been done. I don't know. I don't know how anybody can ask, right? Is there not evidence or challenge the evidence that's out there? It's unequivocal that supplemental screening just finds more cancers. So again, I just want to throw my 2 cents in as a layperson. If you start searching on in the internet, and you'll see that there are many peer-reviewed scientific journals that have studies that show that abbreviated breast MRI, ultrasound, MBI, right, just find so many more cancers relative to mammograms.
Thank you for that. So we have so many questions.
I just want to add one more thing. That doesn't mean you shouldn't get your mammogram, because we know that the death rate from breast cancer has gone down substantially. And I don't want to leave people with the idea that, no, I'm not going to get a mammogram. I'm just going to get one of these supplemental. We need them both. It's really about the different technologies that show different characteristics, that using a strategic approach to risk-based screening, we can find more curable early breast cancers.
Agree.
So I think that's key, Dr. Brem. It's a 2-step process. And I think women have to be told, if you have dense breasts, you don't get away with just doing the mammogram. It's a 2-step process for you. Mammogram followed by an ultrasound or a breast MRI. And it can be even an abbreviated breast MRI. I mean, that's what I understand now. I wish I had understood that years ago, but it seems like that's the case.
And that is what we do at our practice. So there are some practices that do offer it. And, it's important to realize that what we need to do, and even in our practice that we offer it, some women don't get it because they have to put food on the table in the evening. So we have to make it available and accessible to everybody.
Okay. Sorry. So I'm looking at a question, and it's multifaceted. So I want to tackle it. I think this would be open for the entire panel, but an anonymous attendee wants to know, so if the issue is regarding insurance coverage, and insurance coverage is based on the standard of care, which is based on clinical trials, since clinical trials don't include enough Black women and minorities who tend to have more incidents of dense breasts, then the threshold that triggers additional screening won't move because the standard of care bar is too high. What will be the standard of care trigger for MRI, ultrasound, after the legislation if this doesn't change? So I just think that they're saying that our assessment of what the baseline for high risk will be skewed because we don't have enough representation in our clinical trials. And so they want to know how, if this legislation is put in place, how that will benefit the patients that are excluded from studies but still are affected by dense breast tissue and breast cancer.
I can start and then somebody can correct me when I said something wrong. But it seems to me that the common factor between women of color and younger women is they both have dense breasts. So in that sense, right, we share common attributes. So I think you can carry over the data that's done, even if it doesn't have as many of us minority women in the study. I still think we can take away the benefit of the learnings as long as there were women with dense breasts. You see what I'm saying? In this area, Christine, women of color are very much the same as younger white women because of the fact that we both have dense breasts. And whatever we learn from younger white women carries over to minority women of all different ages. We both have the same phenotype, dense breasts.
One way of saying that maybe is that X-rays are colorblind. They go right to the tissue.
Yeah, I like that.
And
that's a good way.
It's hard to find the snowball and the snowstorm. And that snowstorm is when you've got dense breasts and you can't see that snowball, right? And it doesn't matter what your skin color is or what your genetic makeup is in terms of the mammogram itself. There are other factors such as genetic makeup and other things which confer other risk factors, but not for the X-rays.
Thank you. We have a lot of questions. Oh, sorry.
We do have to still specifically look at populations where the days of, targeted therapies and personalized medicine. So I do want to encourage all people, and especially women of color, and especially underrepresented women to participate in clinical trials, because we don't know what your targeted personalized medical needs are unless you participate in them. So in some ways we can extrapolate, dense breast is dense breast, but the impact of additional screening in different populations, I think, is very clear, but we still need in clinical trials, different populations to help us help everybody.
That's a universal statement though, Dr. Brem, I would say, right? Not just specific to breast cancer screening.
Everything.
The good news is I know that the Brem Foundation and also My Density Matters are part of the newly formed American Cancer Society National Breast Cancer Roundtable. That's a mouthful. And a lot of what is discussed in that roundtable are the things that Christine brought up, that women of color are not represented well in our risk models right now, and need for better representation in clinical trials. So to your point, yes, and I do think that things are getting better.
Thank you. So I'm going to try and combine a lot of questions because we're running low on time. A lot of people are really concerned or curious about what the guidelines are and why this information isn't more widely known by health professionals. And so they're trying to understand why, if these are what the guidelines are, why professionals aren't getting this information, and what's the miscommunication that's occurring. And this will be our last question.
So I can start. There's many organizations that issue guidelines, and one problem is that they have never all reached consensus with one another. So if you look up on the internet, for example, you might see 5 different answers for this. This points to a need for some strong unified guidelines. One organization that could really help do that is the U.S. Preventive Services Task Force, but as of yet, they have not issued any specific recommendations for supplemental screening, which is a problem. I agree this is an issue, and hopefully events such as this today can help spread awareness. We need to do better to issue very clear, direct, and impactful science-driven guidelines to answer this question. But as of yet, not quite there.
So I want to raise a related topic. It seems to me that it would be very helpful if the mammogram reports were more clearly worded, right? Telling a patient that there's no sign of malignancy, come back 1 year for a mammogram, but then having a little legal disclaimer saying, hey, you have heterogeneously dense breasts and small masses may be obscured. Sounds like at best doublespeak. What should be said is you have heterogeneously dense breasts. We recommend a breast MRI or ultrasound to confirm that you do not have cancer. I mean, it really, I mean, as a lawyer, right, if you go to get a loan document, you know, some kind of loan, the loan document you get has all the truth in lending information. Why is it when it comes to medical tests, we get such doublespeak?
Well,
I mean, I'm a fairly intelligent person, right? And I didn't understand what they were saying to me.
Okay. I think you all made great points that we need clear communication about the guidelines, the evidence, and also we need to put this information in context for patients. That way they can be better, they can advocate for themselves if necessary. So with that, I'll conclude our Q&A session. I'd like to thank everyone for dialing in today. We will be sending a recording, and we do urge you to sign our petition to contact your member of Congress and ask them to find ways to get insurance companies to cover these costs, whether it be through government or private insurance. We need to find ways to cover supplemental imaging technologies for patients. Many lives are dependent on this. So thank you once again.